Good morning and welcome. My name is Alyssa, and I am the Adolescent Outreach Coordinator for SunCloud Health. SunCloud Health is an integrative and comprehensive mental health treatment facility. We treat both adolescents and adults, specializing in substance use disorder, eating disorder, mood disorders, and all relating back to trauma. So we have PHP and IOP programs at all three of our locations in Northbrook, Naperville, and Chicago. And we also have a residential treatment facility for adults in Northbrook as well. So today I'm very excited to introduce our facilitators, Dr. Alexander Chevalier, who is our medical director for our adolescent and child psychiatry, and Dr. Kim Dennis, who is our CEO and Chief Medical Director for SunCloud Health. Today's topic, what lurks beneath and lies above, relating back to substance use in teens with depression and anxiety, and really kind of our, approach here at SunCloud Health when it comes to that topic. This is a topic that's very near and dear to our hearts. So without further ado, I'm going to hand it over. Also, really quickly, I'm going to throw my email address in the chat. We are offering one CEU for our topic today. So I will, if you are interested in that, please email me. And all right, I'm turning it over. Enjoy.
Thank you, Alyssa. So again, my name is Dr. Alex Chevalier. I appreciate everybody joining us bright and early this Friday morning. This is going to be a somewhat dense talk, which is what I'm sure everybody's looking forward to on their Friday mornings. But we're also going to have Dr. Dennis helping us through some of that. So we will try to make it as engaging as possible while also making sure that we're including the most recent and up-to-date science, which is what you come here for. So with that said, today, we're going to talk a little bit about alcohol, nicotine, and cannabis, overwhelmingly the three substances used by adolescents, as well as depression and anxiety, the two most common non-substance related disorders in adolescents. And then really at the end, get to the interactions between these two and the pernicious ways they can play off of each other. And then a little bit about how we go about treating these complicated comorbid situations. All right, so to start things off with, everybody wants to talk about in the morning, alcohol 101. So I had a lot of background in chemistry before I got into medicine. And so you'll always see my slides with things like ETOH, which is a chemical of ethanol, which is what you're actually consuming when you say alcohol. Of course, there are many alcohol products. There's a whole bunch of different types of alcohol. That's just a chemical term for something ending in an OH group. But what we really mean is ethanol. Ethanol is probably the oldest known intoxicant to mankind. There's good evidence for use over 9,000 years ago. But it is also one of the most confusing of all the intoxicants. It is very difficult to study despite being an incredibly simple molecule. And that is due to its very unusual properties. It has a very low molecular weight and is also a very lowly potent compound. So traditional assays that are used to detect and look at how other chemicals work do not work the same way with alcohol. Alcohol also has, or ethanol again here, has a huge number of effects on the system. It is what we would call, if it was a pharmaceutical agent, like a dirty drug. It binds to many, many, many different receptors and causes many, many, many different interactions. So for the purpose of breaking this down, we typically think about alcohol as being principally something that works through the GABA system. It increases flow through the GABA receptors and potentiates those receptors. And so when we think about the intoxication profiles, the withdrawal profiles of alcohol, it's typically mediated by the GABAergic system. However, as I just mentioned, it has many other effects, and it certainly also activates the dopamine system in the addiction pathway of the brain, which we'll be talking about later. And it also affects the opioid system, which is used partially in how it's treated with pharmacologic intervention, and also relates to how it creates addiction. Alcohol is classified as a group 1 carcinogen, is responsible for a large number of cancers, something that was not commonly thought of with alcohol until more recent times. Everybody thinks about tobacco and smoking, but alcohol is absolutely in the same category of carcinogen, and is actually the third leading cause of preventable death in the US, related both to its negative effects on the body and its acute intoxication, and unfortunately in its acute withdrawal effects as well. So thinking about the adolescent population, I am a child and adolescent psychiatrist, and we get to talk about adolescents all day today. So everything we're going to talk about is going to be very adolescent focused. We have a wonderful annual survey that's done in America called Monitoring the Future, or the MTF data. This is the holy grail of adolescent health data for all of America. We survey teenagers throughout the whole US in a representative sample, and have been doing this for many, many years, to have multiple decades since I was a kid, to have data to look back on as well. I'm going to present you the most recent data in 2021 that you're seeing on the slide below. In here, you'll see 8th graders having a 17% chance of using alcohol in the past year, 10th graders 28.5, and then 12th graders 46.5, which is almost half. I have daily use listed here. It's going to be more relevant for the next substances we're talking about, but just as a point of reference, the interesting thing about these data, in contrast to adults, is that substance use actually reduced substantially following the pandemic in adolescents. Adolescents tend to acquire substances through their close social networks, which are derived by school, but also even outside of school, really in an in-person kind of way. Of course, adolescents can't just walk to the store and buy alcohol. They can't walk to a dispensary and buy marijuana. Most of the time, we have plenty of patients who somehow have found places in the city that will sell both of those things to people who are underage. But typically speaking, when we're thinking about these substances, these are things that are not legally accessible to adolescents. And so there's been a real demonstration that access to substance certainly drives substance use. And then also, when you're thinking about alcohol use in particular, there's a lot of alcohol use in adolescence that's done in larger, like, party gathering settings, and those are limited significantly by the pandemic. Even in 2021, I know it's a little hard to think about here in 2022, where we're pretty much back to normal, outside of wearing masks here and there. But even last year, when we were hitting the variants and going through that really cramped down on people's abilities to get together that were adolescents. So the sobering news with these numbers is, as bad as it is to have 50% of almost 12th graders using, it was actually substantially worse in the past. And there's definitely concern for these numbers having a big rise over the next couple of years. One is that kind of pent up thing that everybody's experienced after the pandemic, like, let's get together in huge throngs, let's party, let's let off some steam. And two, just what we'll talk about how there's some new risks to adolescents with substance use. All right. I also wanted to briefly touch on some interesting data that we are starting to get in the child range, which is somehow even more sobering. So there's a large research cohort. It's called the ABCD study. This is going to be hopefully another holy grail of pediatric age range research. These are kids who are tracked both using neuroimaging for all of the cohort, which is why it's such an incredible undertaking. This is like the Manhattan Project of adolescent and childhood brain development. To give you, just some perspective for the scope of what this is looking at. We're using a tiny sliver of that data that we're going to be talking about here today. It's going to be many years in the future for the definitive things. But when these studies come out, they will be, in JAMA, in Nature, in Science, and all the biggest journal articles, and have the biggest and best people in the field working on this. So in the 9 to 10-year-olds, just based on sample data, we already had 10% who reported curiosity about alcohol and tobacco use. 3% reported that a friend was already using substances. And again, this is, 3rd and 4th graders that we're talking about here. 35% who were saying that they had easy access to alcohol. I don't know what I don't even remember considering what alcohol was as a substance when I was in 3rd and 4th grade. And so this is already a third of kids who are reporting that they can conceptualize access to, this substance. I think one of the interesting things to look at when you're looking at young kids is one of the things they found about where the highest curiosities were. Not surprisingly, it was in boys. Males have higher rates than females across the board with substance use. It doesn't matter what age you're looking at. But some things I thought that were kind of interesting. The higher household incomes definitely had higher curiosity. They reported having higher access to substances. Of course, peers using was the number one and worst indicator for where things were going. This data also showed that Caucasian households had higher rates, and actually Black and Hispanic households had lower rates and were more likely to talk to their kids about not using substances. Not that this is necessarily a surprising thing, but I think something that sometimes gets glossed over or kind of missed by people is just how mainstream this is in high income and particularly Caucasian households. Pass it over to Dr. Dennis here now.
Yes, thank you, Alex. So I'm going to talk about, we're going to shift over and talk a little bit about vaping and nicotine. And this has unleashed a whole new epidemic of substance use for young people. Vaping first came onto the market in 2007, and it has really exploded onto the scene since then. Vaping pods contain much higher nicotine content than a cigarette. And importantly, it crosses the blood-brain barrier at a much higher rate. And one of the things that we know about capacity of a substance to develop, to trigger addiction and the addiction neurocircuitry is how quickly that substance crosses the blood-brain barrier. So it's a very quick onset and high peak that results from vaping pods. We know that the marketing of vapes has heavily targeted teenagers and young people. Coloring, pastels, tying it to cartoons, flavors, cotton candy, birthday cake, all sorts of fun flavors. And kids and adolescents are able to quickly develop physical dependence on higher quantities and higher concentrations of nicotine. Kids are also able to do this under wraps. They fly under the radar because the vape can look like a hard drive on a computer or a thumb drive on a computer. The vape can look like a pen. They're able to do this all throughout the school day. Vaping nicotine was associated with a 350% rate of increase of cannabis use compared to non-vaping peers. And those two are intricately connected. One of the things, Dr. Chevalier mentioned, kind of surprisingly, adolescent substance use during the pandemic decreased, and with adults, including young adults, we saw skyrocketing rates, right? One of the other pieces that I think contributed to that decrease is parents were home, right? We know that one of the risks for substance use in adolescence is less in the way of parental oversight. So during the pandemic, everybody was home. Parents were home. Kids were with their parents for a much, much, much higher percentage of their week than really ever before. So when it comes to vaping, you could see somebody take a drink of alcohol. And again, because the method of distributing this substance into the child's body, into the adolescent's body is so undercover, we've continued to see high rates of vaping even through the pandemic. We also know that nicotine has independent negative cognitive as well as physical effects. It impacts the reward pathway. One of the pieces that I think people fail to appreciate is once that reward pathway is primed, we see much, much higher rates of substance use disorders, regardless of specific substance down the line. This is a slide based on a 2014 study that showed percentage of e-cigarette use in high school students, that's the top dotted line, compared to middle school students. And shockingly, 25%, that's a quarter of all 18 to 25-year-olds in this study were using e-cigarettes. That is a huge increase from tobacco use 20 years ago, 10 years ago, well, I guess not 10 years ago now, but 15 years ago, early 2000s, before we had vapes and e-cigarettes, tobacco use percentages were much lower among high school students than what we're seeing. So there's been a massive increase. If you look at the data just from 2017 to 2018, particularly in the high school students. You can see the slope of that increase, which is alarming. And this started back in 2007. Silicon Valley startup, Juul, used savvy social media, again, targeting adolescents. It was, it was cool, it was trendy. I remember, this was probably about 5 years ago now, the ISKIPA conference, which is the International Young People in AA convention, was in downtown Chicago. I was asked to speak as one of the professionals, and swarms and swarms and swarms of young people, all vaping, all the time. It was shocking to me to see it and to experience that in such high concentration, up close and personal. We know that there has been recent litigation and accountability that has been held to Juul and other companies like it. Just very, very recently, they settled a $438.5 million lawsuit with several states. The technology that's used by PAX Labs, which is the sort of foundation for some of these companies, provides a highly, highly addictive means of consumption. And again, this is both because the concentration of nicotine in the vape juice is much, much higher than what a cigarette would deliver. And also the rate of absorption through the blood-brain barrier is very, very high. And as I referenced before, the vape and marijuana industries are inextricably connected. Kids that vape nicotine are much, much more likely to also vape marijuana, THC, cannabis.
Yeah, and I think you can even see here, just with our images, how similar these devices look. It can be very difficult to know, if you're somebody who's using nicotine, is this vape going to contain nicotine, or is it going to contain up to 100% pure THC? So,
right, and impossible for parents to know, right? Just by looking at it.
So just transitioning from alcohol to nicotine now into marijuana here. This is just giving you some idea of ways in which marijuana is now being consumed, a very different world than has been the case even since when I was a kid growing up. You see these 100% legal, suckers that people are having, these edibles being infused into beverages. It's now the trendy thing to be infused into alcoholic beverages. Which is not pictured here, but will be a new thing to contend with for adolescents going forward, to get a twofer to deal with there. So we just mentioned quickly in the past, these THC companies, much like the vape companies, are really going after the youth. We're talking Comic-Con conventions here, superheroes. Here you're seeing kind of this now somewhat older advertisement, but telling you it's 72% pure to be the most potent, as though we're racing, to this. We've now subsequently got to 100% pure. So this race was on for a number of years. It kind of shadows some of the really scary things we've seen in the opioid epidemic, where, dealers would increase fentanyl concentrations. If somebody died from it, people would go to them to purchase opioids from them because they knew how potent that dealer's supply was. And so you're seeing the exact same thing happen here, and it being advertised proudly as such. And so let's talk about cannabis real quick here. So marijuana is the name that's just been colloquially given to the cannabis's plants' psychoactive components. So we really think about the main psychoactive component, which is THC, tetrahydrocannabinol, not cannabidiol. And that's really what we're talking about. But there are actually, many, many, many psychoactive components to marijuana. Marijuana is also extremely tricky to research. You'll see a trend there between it and alcohol. Despite them being so widespread, they're very difficult to fully capture and understand because of the high number of different compounds that are present and how those can vary between plant to plant. It is actually a very, very complicated place to be, and there is still ongoing research, certainly, into this area. Cannabis use is dated back at least 2,000 years, probably closer to 3,000 years, but it's a very different world since when these plants were originally harvested out of the ground, which we're going to talk about a bit here.
So the endocannabinoid system is throughout the whole body, much like serotonin receptors. We find serotonin receptors in the GI tract, in our blood cells. When we look at areas of the body that have the CB1 and the CB2 receptors, we see the brain, the lungs, the vascular system, our digestive system, reproductive organs, our immune system. So it has a multi-system effect and impact. We'll be focusing mainly on the impact that it has on the brain today. And this is a schematic that shows really in a very, very basic, simplified way, the reward circuitry and how this reward circuitry is altered in addiction. One of the primary areas that I'd like you to focus on, so this is a system that starts in the brainstem by the ventral tegmental area. Dopaminergic neurons from the ventral tegmental area then project to the prefrontal cortex as well as to the basal ganglia. This arm that goes to the prefrontal cortex significantly interrupts areas of the brain that are involved in executive functioning, significantly impacts a kid's capacity to, for example, make a plan and stick with it, to put off reward, delay reward for a higher goal. This area of the brain is offline, essentially, when addiction or pre-addiction, as Nora Volkow recently talked about, which I think is a brilliant and important piece of what we've missed, particularly with adolescents. Oftentimes, kids that we see that come to our program have had neuropsychological testing and they have ADHD. Very, very few of the people that have had neuropsych testing have really any documented history of substance use in the neuropsych tests. I can't think of any that come in with, my neuropsychologist wanted a urine tox to see if substances were impacting my brain function. It just isn't done. So some of these kids do have ADHD. There's a huge overlap between substance use disorders and ADHD, and some of them just don't. They have PTSD or complex trauma and substance use. The other arm of this that I think is really important is the extended amygdala. So the prefrontal cortex links back down to the amygdala, hippocampus, and this is really what mediates what we know and what we'll talk about further on, the memory issues that come up, the apathy and the amotivation that comes up, and over the long haul of use with chronic use of THC in particular, we start to see increasing levels of anxiety, increasing levels of depression. And the other thing to know about this circuit is, as I mentioned before, once this is primed, it goes from being a sort of a dirt road that's hard to get down to a superhighway. And once it's a superhighway, other substances or behaviors with addiction potential can become baked in, and that's really related to the basal ganglia, this what you see in blue. This top-down loop is very involved in habit and habit formation, and is also responsible for people, even when they really, really, really don't want to use anymore. I'm committed to abstinence. I'm going to do it this time. When that arm is again cemented in. It's impossible for people without intervention, some of them pharmacologic, some of them behavioral, some of them spiritual and emotional, to break that loop and give somebody the amount of time that it takes for the brain to heal, which is beyond 28 days. It's beyond 3 months. It's more along the lines of 9 months, a year, of protecting the brain from toxic insults related to substances. And particularly when we're talking about adolescence and adolescent brain development, when we have THC use in adolescence, it dysregulates this endocannabinoid system. And we see changes in pruning. Brain pruning is continuing to go on. Brain development and growth is continuing to go on, particularly in the areas responsible for executive functioning, the prefrontal cortex, the neocortex, well into the 20s, right? So we see changes in pruning, potentially altered neuronal changes at the level of the sheath covering the neurons. And then we see dysregulation in the GABA and glutamate systems. And this leads to altered neural network connectivity, altered neural circuitry, and then we see impaired behavior. And this, I think oftentimes we think of kids and even older people who are using as, you're just lazy, you're just not trying hard enough, you're just doing you're making bad decisions, or you're leading an unhealthy lifestyle. And we fail to step back and appreciate that there is a disease process going on that is in your brain. The organ that we use to make life decisions and execute plans is the organ that's impaired. And when we look at it from that lens, it's a lot easier to step back and get somebody access to care, to understand that you didn't cause it. It's not from bad parenting. It's not from the kid being a bad kid. It's from a disease process. The good news is that, particularly with early intervention, we can change the trajectory of, ongoing brain development and the kid's life.
Okay, so I told you a little bit about how THC has changed since prehistoric times. I don't have data back to Woodstock, which is what I like to frequently reference, but if I could, I think most of them are still showing up on this blue line, by the way, is THC percentage. And I think at most of the references I've seen to Woodstock have been around 4% potency. So actually THC was pretty flat and in its concentration in the actual plant matter that was consumed and smoked for many years. And then as we've seen, with the rapid rise in concentrations of THC concentrate, there's been a similar rapid and actually even higher by percentage-wise increase in the concentration of THC in the plant matter itself. So obviously plant agronomists and selective breeding for things has been a mainstay of human evolution over the past couple millennia. But now that there's big money in marijuana and people want more and more potent products to keep up with the tolerance that they're getting to the substances, we have seen this significantly increased concentration. This only goes to 2018. I've seen some strands now that are getting up to 20%. So again, you're going from 4% to at least 15.6 here, if not higher. I mean, you're talking about a 400% increase in the potency. So passing around that joint at Woodstock compared to passing around the joint at a concert 5 years ago, it's 4 times the concentration with each puff that you're taking in if you're using the classical plant matter, although that's relatively uncommon and for older people these days, I guess is what the teenagers tell me. Just a nice quote here. This is talking about just the difference in potency, and so this is not something that's new to substance use researchers. Certainly not somebody new to a space work in the adolescent space. Just the difference in potency makes a huge difference. So we're going to talk a little bit more about that now. Here are some studies that were done, and this is again even before the meteoric rise in potencies that we've seen since that. So these numbers are probably on the nice, happy side of things. And as you can see, they're pretty unhappy. Higher THC levels increase depression severity for cannabis users, increase anxiety symptom severity for cannabis users. They also increase the rate of going on to have a cannabis use disorder or formalized addiction, as we'd be talking about. And then kind of more scarily than, well, I don't know about more scarily, but certainly very scarily compared to all of those, is those who are using concentrations greater than 10% here have a significantly higher rate of psychotic disorders. And, you know, this is kind of the terminal worst case scenario with cannabis use, is this emergence of psychotic disorders. As psychiatrists, you know, we grew up on treating people with psychotic disorders, and it's, you know, a very scary thing to see, a huge life-altering event when it's going on and completely changes the trajectory of somebody's life. And, you know, even when you're looking at folks who have kind of rare use, low amount of use from low concentrations, less than once a week, even daily use of low potency THC, it's really bad compared to not using it all, but it is just dwarfed by the daily use of high concentration THC. And the thing that makes me feel particularly uncomfortable when looking at this slide here, which is using, you know, it's recent data. So this is high potency THC like we're talking about. This isn't stuff from even 10 years ago. But again, when you're taking a look at how teenagers are actually consuming THC, certainly the ones with the severe THC use disorders, you're talking about kids who are vaping, you know, 80 to 100% pure THC. So 10% here looks terrible, and it's a joke compared to what's actually being consumed, you know, just over the last handful of years. Okay, so bearing the lead there, vaping THC, you can see a picture of what a vape pen looks like here off to the side. Very small, thin, light, easy to conceal. People are flying with these things on airplanes. I had a patient just tell me that they you know, had tried marijuana as a plant, wasn't that exciting. A couple of years later, went to Hawaii, so across an ocean with their family. Sister brought a vape pen with them, and then the fun game was to see like how high you could get without parents noticing, you know, every couple of minutes when they weren't paying attention. The reason for that is similar to the nicotine vaping that we're talking about. The odor is very minimal. With these vape devices, they may last only for a few seconds. And so they don't, you know, stain your clothes. You know, when I was in high school, there's very little THC use just generally, but even those, the kids who smoked THC, everybody knew they were stoners. I mean, they smelled like marijuana. It wasn't like a, whoa, I can't believe that kid's using. You know, you walked into, you know, school in the morning, the 3 out of 400 kids in my class that were getting high before school, everybody knew what was going on. This wasn't a secret. Right, it's a completely different world with the THC vape pens here. Just like in nicotine, this vaporized form of THC gets absorbed through the alveoli in your lungs faster and easier, and is already at purities. You know, if you compare to 4%, you know, in the plant matter to 100%, it's a 25x, you know, increase of a substance. There are very few, and that's not even counting the increased diffusion. So what your brain is seeing is actually even significantly higher than that. And there are very few substances on Earth where you can just go 25, 30x what people are using and expect to not have problems. Even water, if you have 25 or 30 times the consumption that a human being should have in a day, it can be a deadly substance. So this is part of the reason why we're seeing the problems that we are. And just to get back to the patient example, you know, subsequent to that, in addition to being able to bring one of these things somehow through airport security, I don't exactly know how that happened, if it was a checked bag or they somehow got it through the scanners. You know, in addition to that, this one pen, you know, is sufficient for getting these 2 kids high throughout the entire week, just high off of their mind the entire time. So you're not having to bring like an 1/8 of an ounce of plant matter with you through this thing and like put it into, you know, a joint or put it into a pipe or something like that to smoke and all the things that go along with that. You take this tiny little pen that you somehow got halfway across the Pacific Ocean, and you can get multiple people intoxicated, you know, throughout the entire day for an entire week due to the concentrations that you can fit in one of these pens. Okay, so let's talk about a little bit of the data. Again, MTF data from this past year, 8th graders, 7%, 10th graders, 17%, 12th graders, 30% in the past year. And here you're going to see the daily numbers, which are actually pretty stark. By 12th graders in this year, again, in which we had significantly lower use of substances, we're still around 6% who are daily users. And so essentially 100% of that cohort who's using daily is going to have significant impairment in brain function from this use, is going to have significant impairment in life function from this use, and nothing positive is going to be coming from anybody who's falling into that category. And that category had been as high as almost 7% prior to the pandemic. We certainly have concerns that this number is going to raise further for all the reasons we just talked about, related to the potency, related to the ease of use. We're going to talk about some other reasons that are also not good in just a few seconds if you hang on with me here. I want to say that as bad as this data is, as Dr. Dennis was alluding to before, it is even worse in young adults. And as Dr. Dennis was pointing out, that's a big deal for a couple reasons. One is that brain maturation is still going on, 23, 24 years old for females, probably 26 to 28 years old for males. And so this is the exact range, in which we're seeing 43% using in the past year and 11% using daily for young adults. Again, this is anybody who's falling into this range is going to be having significant issues with their neurocircuitry, with functioning. And so at this age range in particular that we're talking about here. And so what's really concerning is thinking, what's it going to be when instead of this is 6%, this is coming down to 11% or 12% or things like that. So the era of legalization has been tough. There has been a lot of discussion around adult use of cannabis. Comparison of cannabis to alcohol have been brought up over and over again in the legalization arguments. And a huge piece of that missing puzzle that I have essentially never heard discussed by anybody is the impact of legalization, on the youth, for people who are either young and purchasing it and still have developing brains, or for kids, and how it's going to change. And so what we've already seen with legalization is that there's higher use from teenagers in states where cannabis is legalized. Not only is there, of course, increased access because anybody can walk into a dispensary and then go sell it to the kids, which unfortunately is absolutely happening, just like cigarettes were for decades and decades and decades past. So I'm sure everybody in here can imagine the scenarios in which that enterprising 21-year-old wants to take a 50% cut by taking some money from some kids and going to the store and buying it. But in addition to the increase in legal access to this, it's really changed the stigma associated with this. And so, like I said, when I was in high school, it was not a cool thing to smoke marijuana. It might have been cool to smoke some cigarettes, maybe. It's definitely cool to drink, but it was absolutely not a cool thing to come in reeking of cannabis. That wasn't, I just have no experience as a teenager having any conceptualization of that. And nowadays, with how ubiquitous use has become, this is unfortunately something that has gotten extremely accepted by a lot of folks, even from teenagers in high achieving, high functioning situations. There are many who find this to be, pretty acceptable thing. And so this decreased perception of harm, which is at an all-time low for the record, based on emerging data, is very concerning, in addition to the increased access with legalization. Okay, so we want to think about what is different with cannabis on the developing brain versus the mature brain, right? And again, this is, I think, the biggest picture of cannabis use that is not discussed enough. Everybody wants that soundbite, that 5 seconds, cannabis is less harmful than alcohol, cannabis raises $1 billion in tax funding, thing that is just, you get that one sentence thing, it's easy to digest, politicians talk about it, it's on the news cycles, right? But this is obviously a nuanced thing. We're not going to talk about the comparative risk of cannabis versus alcohol in the adult brain. If you want to have that discussion, I think there are reasonable arguments to be had on either side of that. But certainly in the developing brain, it is without a shadow of a doubt a significant concern. Right? There are one amazing study that was done in 2018, and it was able to take a look at seventh graders in Canada prospectively when they were in seventh grade, 4,000, so a very nice sample size. And they got all of these kids to agree to take regular surveys on their alcohol use, their marijuana use, and then also the quantity of alcohol, but not the quantity of marijuana. Importantly, in this study, they were not able to assess for. They didn't have a good way in their mind at the time of doing so. So I want to tell you a few of the results of that study. Risks for using either alcohol or marijuana were premorbid, lower working memory, lower inhibitory control, and lower perceptual reasoning and poor academic function. So not huge surprise. The kids who are most likely to use substances at baseline are those who have less ability to inhibit, less overall intellectual horsepower, and less performance in school. Right. And the last one is probably for the social reasons rather than anything else, although there's obviously stress associated with having low academic functioning that we've seen in ADHD literature over time. The second thing that's really cool about this, because it's a prospective population study, is they were able to look and track and see that kids that were using cannabis, but not alcohol, had had reductions in their delayed memory recall, something that we commonly associate with cannabis, the impairments in the hippocampus with memory formation, but also had reduced perceptual reasoning. And this was felt to be related to an impaired neuroplasticity, so that the defects in the pruning mechanisms that were previously mentioned were causing the brain to not develop the perceptual reasoning that you would otherwise expect it to have. Right. And in addition to impairing neuroplasticity, we also saw cannabis causing neurotoxic effects. So we saw impairments in working memory and in inhibitory control that lasted even a year after use. And so these are not just effects that were happening in the moment while you're acutely intoxicated. These were kids who were using, and then when they stopped using, a year later already had changes in their brain that were occurring. This piggybacks on some other excellent research also done in other countries that have better healthcare systems that can pool data from in Australia and New Zealand that showed that teenagers that were using cannabis on a regular basis, which is actually only 3 to 5 times a week, was there a heavy cannabis use in the older studies. And as we know, it's gotten much worse than that now. In those studies, we were already seeing reduction in intellectual functioning, executive functioning that was occurring again with that chronic use. And in these older studies, that was in the 3 to 5 times a week range. I've got to tell you, most of my patients that struggle with cannabis are using 3 to 5 times a day easily. So easily 7 times what these studies are considering heavy use. Okay. So in addition to that one great study, I'm going to briefly cover here another number of studies that have shown dose-dependent impacts. So that's what you're always looking for when you're looking for correlational studies, right? This is how we figured out that smoking cigarettes caused lung cancer. You were seeing that people who smoked more cigarettes had higher rates of lung cancer. You smoked a medium amount of cigarettes, you had medium increased rates in lung cancer. That same statistical technique was able to show dose-dependent impacts of cannabis on academic functioning, occupational functioning, cognitive throughput, psychiatric comorbidity, and then overall substance use outcomes. So that is to say that kids were using higher amounts of cannabis had higher rates of addiction. In addition to this, certainly as a psychiatrist, the cannabis use in adolescence is associated with increased amounts and worsening courses of, which we're also going to talk about in a second here, psychotic disorders, mood disorders, anxiety disorders, and even suicidality. Right. One of the studies that was done here did show that adult onset cannabis use disorders may experience fewer adverse effects, and that's been borne out multiple times in literature. I know there's one study for it here, but even just delaying the use of when cannabis is used makes a huge difference in cannabis outcomes. That data has also been done in alcohol in the past. The age at which a teenager or young adult first drinks alcohol is easily one of the most significant signifiers for the likelihood that they go on to have an alcohol use disorder. And so they found similar things in cannabis in these studies here. Okay, so we talked a lot about substances. Let's talk a little bit here about mood disorders, anxiety disorders, just to get us all on the same page with that. And then we'll talk about the interactions between them. All right, so starting off here first with major depressive disorder, based on pretty recent 2-year-old NIMH data, so the National Institute of Mental Health, 17% of adolescents, which we're identifying as the 12 to 17-year-old age range, has had 1 or more episodes of major depression, and 12% total, not 12% of the 17%. That is to say, 5% had not severe impairment and 12 of those 17%. So a little over 2/3 or around 2/3 of adolescents that have had depression have had severe impairment from depression. So this is one of the number one causes of morbidity in adolescent age range across all things, not just talking about psychiatry, mental health, across anything that could possibly happen to an adolescent. Major depressive disorder, very high in its morbidity. And the really sad part, of course, too, is that less than half of adolescents receive treatment. And so the number for those that did not have severe impairment, around 40%, which actually isn't horrendous for people who aren't having severe impairment. What really bothers me is that less than half of adolescents, 47%, who had severe impairment from their depression were receiving treatment. So these are kids who are like not getting up to go to school, kids who go from being A/B students to failing their classes, dropping out of the sports that were going to get them, college scholarships. And we're talking heavy hitting things, and still less than half getting treatment. Right. This is a place where you start to see big splits between genders. So females at a significantly higher rate than males, 2.5 times to 1 on the latest data in 2020. When I was taught, and I'm not that old, I would like to think about 10 years ago going through residency, this number was less. This split has actually increased over time between females to males. And then something that's kind of near and dear to my heart, the demographic with the highest rate, but is a Freudian slip, was adolescents that were identified as having 2 or more races, right? So 30% of adolescents who are mixed race were finding themselves having a major depressive episode. That number crushes every other possible ethnic or race group. The second highest is actually 18.7 in the Caucasian race. Now, we did not have enough data in the NIMH data to include Pacific Islanders or Native Americans, and those 2 groups would be expected to have pretty high rates based on adult data. So this isn't a full picture, but I think really an under talked about thing in kind of modern era. There's a lot of discussion about individual races, and there's very, very little discussion about people of multiple races. And so NIMH was doing, I think, a solid here to point out this big increase in depression in folks who have multiple races. So just real quick, I'm sure everybody in this call is thinking about major depressive disorder. I'm like, okay, I know my SIGI caps, problems with sleep, guilt, low energy, poor concentration, changes in appetite, psychomotor retardation, and of course, the thing that we care about quite a bit in the suicidal ideation. But this can look a little bit different in adolescence, right? Notably, even the DSM identifies that you can have an irritable mood rather than a depressed mood and still meet criteria for depression. So you see a lot of irritability in many adolescents who have depression. Their mood tends to be much more reactive than it does in adults and older adults with depression. And so, just because a kid doesn't just sit there looking down in the dumps constantly does not mean that they're not depressed. This is a very different picture of how affect appears in the adolescent age range. And then, of course, the behaviors that you see associated with this are just what are happening developmentally. So while adults may not be going to school, adults may not be going to work, adolescents not going to school, not going to after school activities, poor performance in school where they were otherwise doing better, not getting up, not getting out of bed, is a big one. And then, of course, this isolation. And so we're really seeing a lot more of this now when you can put that phone, in your room, put on social media, get yourself into a horribly depressive state and reinforce it with horribly depressive social media. We're seeing that a lot as far as what presentations look like. Right? The other thing to keep in mind with depression in adolescence is that the coping strategies are really limited when you're 14, 15, 16 years old, right? You can't say, hey, I need to take a break and go on vacation. Although I will put the caveat that now you get your 5 mental health days in school, thanks to Governor Pritzker. It's a very new policy. I'd be interested to see how that goes. But generally speaking, adolescents have no ability to say, hey, I need to take a break. I need a mental health day. I need to take some time off. You can't change schools if you're getting mercilessly bullied, if you've had, assault, trauma that's happened at school. You can't just go do things, right? If I'm having a tough day, get my dog in the car, go for a hike. You can't do that when you're an adolescent. And overall, you just lack control. In general, the locus of control is less with you than it is when you're an adult to be able to cope with depression. And so what do we see then in adolescents who are depressed? Well, when you have low mood, when things aren't enjoyable, when you don't experience joy, when you can't see a way out, there's a number of things that we consistently see. One is suicidal ideation. This has been a national, epidemic that's been going on, and it is getting worse and worse. Starting from the year of 2012, the rate of suicidal ideation and the rate of suicide attempts and completions has steadily increased every year. I have not seen the data on the past 2 years with COVID with regards to suicide, but I am sure it will be presented at ACAP this year and is going to be coming out shortly. But I will suffice it to say that 2012 to 2020 is the worst time in recorded history to ever be an adolescent with regards to suicide. So this is a huge issue going on right now. Self-injurious behaviors are pretty common in this group. I often hear kids talk about wanting to feel something. I often hear kids saying that, they want to channel that emotional pain into something physical, so they have a tangible thing to think about. And then I also see kids who actually find relief. You get opioid release when you self-injure. And so there are many kids where it actually does provide them a temporary relief from suffering, as opioids will do. You'll also see a lot of kids start to use substances in response to feeling this down, right? These substances can make you numb. So instead of feeling really bad, you just don't feel anything. And that can certainly be an upgrade for a number of people who are in a bad place. That's negative reinforcement, which is the strongest type of reinforcement. To remove a negative stimuli from somebody is the thing that will make your brain pay the most attention. And that's what these substances are doing. We're going to talk about that a little bit more later. Right? People can feel more relaxed. So somebody was just telling me this week, I use because that's the only way I feel like my old self. When I'm not high, I just don't feel like me, anymore. And we also see a lot of teenagers who engage in disordered eating in response to depressive symptoms, to have control, to feel like they're making progress at something, to prove their worth through physical appearance, all things that we're seeing with adolescent depression. Okay. And then real quickly, let's talk about adolescent anxiety. Adolescent anxiety is horrendously understudied, I will tell you. The latest NIMH data is 20 years old. And so as I just told you, 2 years ago, you had the depressive data. I don't have any data on an entire generation from the National Institute of Mental Health in the United States of America on generalized anxiety disorder, social anxiety disorder. We just do not get good research on anxiety, and it's really for shame. So there's much less known at a population level. For example, I can give you some data from other countries. In a very recent Norwegian study found generalized anxiety disorder rates around 4.5% at age 14. In the latest data 20 years ago showed adolescents at 2.2%. If you're looking at the older adolescent age range where GAD typically spikes, GAD has its highest rates in kind of later adolescence. And so that 14-year age range, where it's already 4.5, is almost assuredly underselling what the rate would be if you sampled 16, 17-year-olds. And there's many that think that this data is going to be much, much worse now. Certainly in clinical practice, we see this more. We even see schools talking about this a lot more. It has actually gotten, thankfully, like a pretty comfortable thing for teenagers to talk about. A lot of schools are talking about how anxiety impacts it, particularly where we are centered out of, or one of our sites in the Northbrook area, with a lot of very competitive schools. Really starting to see some more discussion around it, but the data is very much lacking in GAD. GAD symptoms, again, I'm sure everybody in this call is pretty familiar with. Just to go over, having excessive worry more days than not, that cause significant impairment in life. And they tend to cause, they have to cause 3 of those 6 symptoms according to the DSM: that restlessness, the fatigue, the difficulty with concentration, irritability, muscle tension, which is frequently associated with headaches, and sleep disturbances, trouble falling asleep because of those racing thoughts. Those are the DSM criteria. What we actually see in adolescents, a lot of worry about school performance, the future. In the current generation, a lot of worry about the future of the planet. Certainly the negativity of news, as news has found its way to burrow itself into people's lives more than it had 20 years ago, is definitely not lost on that generation. Global warming is a big deal for our current generation, as is income inequality. These are things that have really gotten into the zeitgeist of our current teenagers, which is personally, I think, amazing, but from a mental health standpoint, certainly something that I see come up frequently as far as a driver for generalized anxiety. Of course, worries about likability by peers is always part of adolescence. That is part and parcel for being an adolescent, but that can get to an extreme and cause significant impairment in a number of adolescents. And then always, again, worries about parental expectations, getting into colleges. Those things haven't necessarily changed, but the data on them and the competitiveness on them certainly has. The top universities, their acceptance rates have plummeted since I was, going through this process 20 years ago. I think people have more of an idea about just how hard and how difficult it is to get into some of these top universities. And in some ways, it almost feels more necessary to a lot of the teenagers that I'm seeing than kind of some of the pressures I saw 20 years ago. Other issues with GAD, of course, is just this frustration with the problems. Like, I'm not sleeping well, I'm not concentrating well, people are finding me annoying and irritable and keyed up and on edge, and I'm tired on top of that all. It's a really unfun way to go through your day. There's this easy desirability to be just like normal or chill. Like, most people don't love spending time around people who are irritable, low energy, not following your conversation very well. When they do, it's to say something snappy, not making for great peer relationships. Right. And I think really historically, anxiety disorders have been discounted by the general population as being like just anxiety, as though again, you can even see that now. People are like fine talking about having an anxiety disorder. It's no big deal. It's a trendy thing, like having a psychoanalyst in Manhattan 30 years ago. It was like a cool thing to talk about at your dinner party. Right. So this is a similar thing where people are just saying, oh, it's anxiety. Right. It's not just anxiety. This is clinically impairing psychiatric disorder. Sequelae from anxiety. I think it was a very nice study that was done a decade ago in Finland. They were able to look at over 2,000 adolescents. Actually, they started with about 3,000, but they got 2,000 to complete this whole study. They all started at the beginning of high school, so right at the start of 9th grade, and then followed them over the preceding 2 years. So to the beginning of their junior year in high school. And this is specifically looking at generalized anxiety and its impacts with substance. So in this study, they found that generalized anxiety disorder in early adolescence, so these kids, as they were starting high school at the beginning of 9th grade, preceded substance use of alcohol and marijuana, even when you controlled for every other co-founder that they could. And this, again, for those of you who haven't looked at data from the Scandinavian countries, they have extremely powerful population data that is able to take a look at many, many, many co-founders that are not always able to be addressed in population samples in the US. And so this is done through very powerful statistical control to really see that GAD was a precursor to the use of alcohol and marijuana. In particular, GAD's effects with alcohol were dramatic. It caused a threefold increase in the likelihood of kids going on to use alcohol if they had GAD at the start of high school over that 2-year period. And again, this is a prospective study. They're not like getting anybody out for any reason. So this is very powerful data to show us the risk factor of generalized anxiety disorder to go on to use substances to manage that. The other thing that they found is that those who were using substances and had GAD were more likely to continue to drink than those who were using substances and had not already started drinking. And so having that baseline anxiety, adding the alcohol to try and manage that anxiety led, of course, to more reinforcement with that going forward.
So how do we put this all together? Dr. Chevalier gave us a wealth of data and science, and now we're left with how do we operationalize this in the service of helping teens and their families who struggle with multiple different psychiatric issues at the same time, as well as substance use, eating disorders, other behaviors. So we understand the typical addiction pathways. And that includes both the acute effects of alcohol and THC and nicotine, particularly, as Dr. Chevalier said, with regards to negative reinforcement. It removes the negative depression, it removes the negative anxiety, it removes the negative trauma burden that is infinitely higher on our teens today than it was in my generation or Alex's generation. We then have to look at the chronic effects of alcohol and THC and nicotine, which eventually leads, just like with other substances, and this is similar to what we see with adults, further depressive symptoms, much more difficult to treat major depressive disorder, and further anxiety symptoms. One of the things that I think we have missed, and an area for us to grow and make a huge impact on teens, is this concept that Nora Volkow is now talking about of pre-addiction, right? We know with most psychiatric illnesses, when we intervene as close as possible to the onset of illness, long-term outcomes are the best. This is particularly true of kids. The neurotoxic effect of alcohol, of THC, of nicotine is much more impactful on a child's brain, on an adolescent's brain, than it would be on my brain. And historically, I think we've looked at teens who've been using substances, and currently, most parents and most communities have normalized teen substance use, right? So, yeah, my kid drinks on the weekends, all of his friends do. What I hear now is my kids, they use THC, they vape, but it's not interfering with school. They're still going to school, they're still getting good grades. And particularly for parents who have girl children or female identifying children, at least they're not getting drunk and getting wasted, which would leave them susceptible to date rape or other terrible, terrible outcomes. So there's been a huge absence of any sort of education or public health alarms being set off, really, on the impact of THC in particular on adolescent brains. Nobody talks about, nobody's talking about the potential for psychosis, which, as Dr. Chevalier said, when we're seeing kids who have histories of THC use, high potency THC use, high frequency THC use, and they're coming in with psychotic symptoms, those syndromes don't seem to respond in the same way as, say, a psychotic depression would to an atypical antipsychotic. It's much, much harder to get somebody back to a state of a linear thought process, a decrease of paranoia or delusional thinking. So we provide psychoeducation to the patient and to the family about the critical nature of being neuroprotective and actively being neuroprotective to reverse the neurobiologic effects of alcohol, THC, and nicotine. We try to promote abstinence in a supportive community environment with accountability baked in, urine toxes, peer accountability, staff accountability. And we support the family, allowing us to manage the disease and us to take sort of that role of bad parent back from the parents. One of the other things that is critical is to look at the family system, to look at parental beliefs about substance use, to look intergenerationally at genetic burden of addiction in the family. Oftentimes, families will have parents who use alcohol every day, but again, are high functioning, lawyers, doctors, so they don't report a family history of alcoholism or a family history of addiction. But when you ask in a more detailed way, is there alcohol at the house? Who uses it? How often? When you ask about the generation above in details, we're able to get a lot more information. And that gives us some sense of where risk lies with this kid. It also, I think, speaks to the critical importance of thinking about trauma burden on our kids, whether or not they have or meet full DSM criteria for post-traumatic stress disorder or complex PTSD. All of the adolescents that have been to our program have experienced traumas. And that would include the pandemic most recently, right? And we look at epigenetics as well. So traumas that have been imprinted on the genes and passed down generation to generation. All of these influence the brain's reward pathway. We know that high cortisol levels leaves people much more susceptible to being in dopamine deficiency states. And these are the people that are seeking something to relieve them of that negative affective state. And more likely to turn to things like food, which kids have pretty much free access to, not if there's food insecurity, which affects a large portion of the US, but food, nicotine, alcohol, especially if it's present in the home, and now marijuana, which is much, much, much more accessible. We support our patients in developing a personal identity with their sober self. We also actively foster connection and attachment in treatment. That's a little bit different than I think most adolescent programs who take a stance of don't talk to people outside of program. There's a lot of fear about these illnesses being contagious illnesses or infectious diseases. They're not infectious. We know that peers and peer influence has a role in disease development, but we do support our adolescents in engaging in pro-recovery activities and having sober fun, both inside and outside of the program. We address co-occurring mood disorders, anxiety disorders, eating disorders, and trauma. And without addressing those pieces all at the same time, we talk about co-occurring disorders a lot, and I don't think people quite understand what we mean by that. We don't mean that this is an alcohol problem that's just been caused by depression or just been caused by trauma. We mean that these are both primary illnesses. We're going to target both in a robust way at the same time to help that kid and their family achieve optimal health, both in the short term and in the long term. I'm going to relatively quickly skip over these slides in the interest of time, but suffice it to say, when we're able to impact the kid and the family system to achieve abstinence, we see improved cognitive performance, we see improved academic performance, we see drops in depression, we see drops in anxiety. That doesn't happen immediately. We know about post-acute withdrawal, we know about acute withdrawal. These are very uncomfortable states, but when kids are connected to a recovery community, to a safe holding space in a treatment setting, they're able to manage and be held through the discomfort to make it to the other side, where their brains aren't being constantly insulted by toxins, and they're learning new skills to be able to implement, to manage their emotions, and to have fulfilling relationships with themselves and other people. So we use pharmacotherapy, we use targeted psychotherapy skills, we do trauma exposures, we use DBT skills, and we address holistic measures as well. So we try to keep people's sleep, get people to a state of restful sleep and adequate sleep. Nutrition has a profound impact on a person's functioning, a person's mood. Exercise. We examine relationship with social media, which can be very toxic for most of our teens that come in, and we look at peer relationships. As I said before, we always have our eye on, where are the attachment traumas? Where are the other life traumas? Where are the systemic traumas that minoritized populations face as well? And we goal set for a future with higher functioning than most adolescents who never need treatment can hope to achieve. And that's, I think, the promise to our adolescents and their families is, most times people are coming into treatment just covered in shame. Families, the kids, they're out of school, I'm off track, all of my friends are doing X, Y, and Z, and here I am sitting in SunCloud, right? And the promise to these kids are, after 3 months, 4 months of treatment and being connected to sustained ongoing care, these kids are set up to go into their college experiences and their lives really well than the well. They've done and begun to do the kind of work that most people don't do until they're in their 30s, 40s, 50s, 60s, ever. So with that, we will wrap up